Е, Приємно бачити таку велику кількість зацікавлених студентів. Сьогодні в нас в гостях пан Василь Вакорін, професор Василь Вакорін. Він приїхав до нас з Канади, з Ванкувера. Це вже, можна сказати, вдруге за рік. Ми зустрічаємось з паном Василем в стінах Українського католицького університету. Я також мав приємність відвідати його університет кілька місяців тому у Ванкувері. Він працює в афілійований з Simon Fraser University, а якщо більш точно, то він є Clinical Neuroimaging Research Scientist в Royal Columbian Hospital при Fraser Health Authority та Professor of Department of Biomedical Physiology and Kinesiology at Simon Fraser University. В нас буде семінар англійською. Заплановано так, що буде коротка вступна лекція з нейронаук. Потім пан Василь розповість про можливості міжнародного стажування, і потім Q&A-сесія. Ми роздали 3 мікрофони, тому чуйтеся вільно, розм'ютуватись і питати. Окей? Good. Тоді я передаю слово пану Василю. The microphone is yours, please.
Okay, thank you, Plan and Astap. So we're collaborating. We have been collaborating for a couple of years, and yeah, again, thank you for invitation and this opportunity to present, to talk about my work. And today, if you have a question or if you want to interrupt me, please do this. So I would prefer to have an informal discussion and rather answer your questions rather than talk about my own research. But also the plan for this seminar or discussion would be, I will quickly introduce you to my research program. Then it would be a quick discussion. I will talk about my research in the context of neuroimaging and neurophysiological tools in general, just a couple of slides. And then I will quickly mention my Mitacs Global program. Deadline is tomorrow for undergraduate students, and questions and answers. So again, if you have questions, please interrupt me at any time. No? Okay. Is this better or it's the same? No? Okay. If I talk like this, is it better? Okay. So did you hear what I said before? Yeah, and так, дякую. Again, sorry, мій активний словник української дуже занедбаний, тому я буду розмовляти англійською, але якщо є питання, будь ласка, in English or in Ukrainian. So I will start with, so I came from Vancouver, so British Columbia, and I'm affiliated with the Fraser Health Authority, which is one of the several administrative health districts. It includes 13 hospitals, and in 4 hospitals, there are EEG units, so where they collect electroencephalography, where they collect electroencephalography tests, and usually they scan about 5,000 people per year. So it's over the year it's accumulated a bunch of very rich, clinically rich neurophysiological data. And so I will start with talking about EEG. So as you can see here, it's a typical clinical setup. Here you can see EEG scanner, which is connected to the amplifier, and the electrodes goes to the head, and it's So each hospital has several stations, and I'm talking specifically about so-called routine clinical EEG. So it's about 30-40 minutes test. Usually it's measures spontaneous brain activity. And there are two functional, EEG technicians administer two functional maneuvers. Usually it's a hyperventilation or deep breathing, or photic stimulation, like a flashing lights in front of eyes. So those maneuvers are known to induce seizures. So that's basically this EEG test is to evaluate epilepsy, first of all. But in general, this brain activity shows a broad array of abnormalities. And for EEG, here you can see what neurologists typically see on the screen. Is just 10 seconds, but just imagine it's a 30-40 minutes. So in general, and their neurologists are trained to evaluate this EEG by eye, like looking into the screen. And so there is, it means that clinical expertise is required, and it is not readily available, in general expensive. Also, it depends on a specific expertise of individual neurologists, and there is a strong so-called inter-rater reliability when the same data can be interpreted differently. And for some neurologists, it might be a spike. For another neurologist, it could be like maybe part of the normal pattern in the data. And of course, there are lots of artifacts. And so that's why, in general, interclinician variability is moderate. So it's not. And yes, please. Usually, it's a highly sampled signal, about 500 hertz. So it's a 500 time points per second. And there are different rhythms, brain rhythms, which are like first of all, alpha rhythm around 10 hertz. And they look into the distribution of alpha rhythm, asymmetry, and probably acceleration or slowing of alpha rhythm. So they are somehow trained to look at these signals and find abnormalities. And I'm apologizing for my weird accent and pronunciation. I'm wearing braces. Sorry. So that's why, in general, the EEG activity is quite complex. First of all, there is many sensors. Like usually, if the clinical setup, it's like 20 sensors plus some like A1, A2, like and which is in clinical setup, it's like 20 sensors is relatively small. It could be up to 64, like 128, possibly up to 256, but those are usually like in lab settings. So, but even still, imagine like a highly sampled signals, 40 minutes, and here you can see it's essential, it's a 10-15 seconds. So, and there are all different in spectral domain, signals are quite complex as well. Also, this is temporal variability is huge. So signal complexity is very large, and there is opportunities for AI apparently. It's definitely, and this is what one of my key projects is about. So we're trying to develop AI tools to help neurologists to deal with this data somehow. In general, they're totally fine with this. They're without any AI in general. But so it's a really, the problem is to find applications which really can help doctors, because this is like healthcare is a very conservative field, and if they don't understand, they would not use this. And in general, it's their responsibility. Ultimately, they have to sign the documents. So, but I was able to build up a collaborative team, which includes neuroscientists and neurologists also. We're collaborating with the King's College London in the UK. And so, and there is multiple components. First of all, it's electronic health records. And we're trying to come very diverse labels somehow. And ultimately on the second layer, or ultimate layer, we want to apply and develop and test some algorithm, the AI tools, in predicting clinically relevant labels from brain signals. So specifically in this project we're talking about, it's about 40,000 records, which was collected almost 6 years ago. So still we have approximately, we need to get another 40,000 records. So I said 40,000 records. Oh, and data includes some labels like males, females, and neurological reports, which is it's a clinical, it's expert knowledge. So when neurologists look into the EEG, ultimately they dictate a report, which is a half a page or up to a page, semi-structured medical text describing what they see in the data. And so it's part of the report is the neurophysiological evaluation of the data, and ultimately it's a clinical impression. So, and for it's both, there are inpatients and outpatients, and for inpatients we have slightly more information like diagnostic information. For inpatients, it's a patient who stay in the hospital for at least one day. Outpatients, they have a referral from a physician, and they go to EEG unit just for the test, and then. So, and as I mentioned, this EEG report are our primary source of clinical labels, and we developed a classification scheme so it's a semi-structured text, and we want to extract this data, these labels in a structured way from all these EEG reports. So first of all, we proposed a classification schema, which is, well, not really our initiative, is essentially, it's a part of the standard evaluation. So first of all, so we're just following the neurologist. So when we see EEG, so we're trying to determine if it's EEG normal or abnormal. Keep in mind that EEG is not, it can support the diagnosing epilepsy, but it's not really a test for epilepsy or for seizures. It just, when we see the data, so we first neurologists look into this data, and they say if it's normal or abnormal EEG. If it's abnormal, then we have it could be epileptiform or non-epileptiform abnormalities. And then there is some more complex, like more fine classification. It could be focal or local, they call focal, or generalized. Yes, please. Again, so EEG does not evaluate the health in general. So potentially, a patient might have a referral for EEG, but it's not sure, like, for what reason exactly. So maybe there was one person lost his consciousness So what was like, maybe it was heart, maybe some problems with the blood flow, or maybe it was some kind of seizures. So they don't know. So they suspect it might help in diagnosing. So that's why they just sent to EEG clinic. And then for 30 minutes, neurologists have this window, like 30, 40 minutes, and they see, okay, if does it look EEG normal or abnormal? So yeah, that's a problem. So there are some known patterns in EEG, like epileptic spikes, which has a specific patterns. So, but in general, the problem is that the same data could be evaluated differently. Even the same neurologist could evaluate the same data differently, like with some time interval. So so this called inter-rate variability is not high, but it's not low. So it's moderate. Let's, for example, like 70, 80%. So there is again, I would say lots of variability in evaluation because it's just like like they are trained and there are individual institutional biases. And it depends on the school, on how it might be some less experienced neurologists, like resident fellows, and very experienced neurologists. So usually less experienced neurologist would tend to find more abnormalities. Probably he would be scared to miss some abnormal cases. So that's, yeah. Does it answer your question? So in general, there are known specific patterns, but they are variable, and interpretation of them is also variable. So it depends. Yeah, definitely. It's a very interesting question. So ultimately, it's a question about when we have two EEG scans from the same person, and if we can compare these scans to scans from other people. And it's really, yeah, indeed, it's very close to even like if you scan yourself like twice. In general, because variability across people is very huge, like in terms of alpha frequency, but it might be stable. Like alpha frequency, in my opinion, alpha or mu frequency are relatively stable during like a spontaneous activity or task. So it might be some elements of EEG is a stable patterns of specific individuals. But in general, of course, there are lots of variability, which can be induced metabolism or medications. Yes. Potentially, yes. So if there is if they suspect epilepsy, so sometimes patients have to wear EEG devices it's called ambulatory EEG, not routine EEG, so but for several hours, even like at home for a couple of days, and they monitor activity. And there are lots of already these days, there are tools, AI tools, which can potentially detect epileptic discharges in those like hours of EEG. So yeah, exactly. So it could be done. But for routine EEG, like 30 minutes, and this is what they have essentially. Again, it's the reason for EEG is to say if it's normal or abnormal EEG. So diagnosis is a more broad concept. Diagnosis is based on the clinical symptoms, on the history. And EEG is just part of this. It's just one small, like a blood test. So it might help to make it a correct diagnosis, but it make it things worse. So it really depends. Yes, please. No, it's rather like for a given EEG, neurologists are looking into this data and they say, okay, there is if data normal, abnormal, what kind of abnormalities are present in this data. But sometimes if it's when it comes to the diagnosing epilepsy, for example, so it might be a weak history of symptoms, and then EEG is incorrect, is misread. So like, for example, it's normal, but it was read as abnormal by neurologist. And then, so then you have a incorrectly diagnosed epilepsy. They put you on, let's say, 2 types of drugs for a few months. It does not work. They switch drugs, and apparently with some side effect. So it happens. So that's why with the AI tools, we want to really improve interpretation of EEG signals. Yeah, so, and in particular in our cases, so we prepared, so we have 40,000 scans, so we used some pre-processing and also source reconstruction to evaluate activity inside the brain, even from like 20 channels, but there are some algorithms which allow us to reconstruct activity in specific brain regions. And some applications we used just for toy models. So we used EEG to predict brain age with hypothesis that the deviation from the predicted and chronological age would be correlated with the clinical symptoms. And Ostap was leading this project, and like one paper published, and so another in preparation. And also we look into because we have data from essentially from 1 year old to 100 years old, so we can look into the EEG parameters, and we can look into how those EEG parameters change across the lifespan. So sort of constructing a brain chart reference models. And also one of the projects, so really we want to develop foundation models for EEG. It's like a sort of chat GPT, but for EEG. I'm not sure again how to advance this direction, but at least one grant application is under review, so we'll see how it would go. And also we extracted clinical labels from EEG reports, so like we applied large language models to medical text, so some EEG reports were annotated manually by EEG technicians, so we assume that we know the truth the true labels, and then we applied LLM models like Mistral, and it shows reasonable performance. So language models can approximate human performance. No, in this case, it was just text. So we have EEG already. So we have EEG. Then it was evaluated by neurologists. They dictated a report. So it's, let's say, half a page of text, of medical text. And then EEG technician look into this data and they say, are they talking about normal or abnormal evaluation? If abnormal, if it's a epileptic form or non-epileptic form. And then they were annotated manually, or part of the reports. And then we applied language models, and the performance was reasonably good. And I want to provide you like a context of EEG. So in general, you see in terms of temporal and spatial resolution. So EEG has a high temporal resolution. Let's say it's 10 milliseconds, for example, but very low spatial resolution. And we're talking about, it's a non-invasive instrument, but it's just 20 channels. So compared to MRI, which has much better spatial resolution, but the temporal resolution is much poor. It's so-so. For functional MRI, we're talking about seconds. So it's essentially like 1 point per second. And positron, the PET scan also, it's more for structural data. There is another technology called magnetoencephalography, which is an expensive version of EEG. And this is electrocardiography and electrode arrays, which are basically it's invasive tools. And for EEG and MEG, we're capturing activity from a large, let's say, 50,000 neurons activated synchronously. And while for electrocardiography, we capture an activity from, it's maybe activity within several millimeters. And how it's, again, so this is how MEG looks like, which is it's an expensive version of EEG for this, because you still need, they're trying to capture tiny magnetic fields, and these sensors, which is called squids, also they operate at very low temperatures, so it needs liquid helium, which is expensive, and evaporation, so still maintenance is quite expensive, but brain is transparent to magnetic fields compared to the electric field, so it's ultimately, here we have like 300 channels, and because of, again, brain is transparent to the magnetic fields, we can do so-called source reconstruction, so we can see better what's inside the brain. And so I quickly want to again, just a picture to illustrate source reconstruction. So let's say if you assume there are channels outside of the brain, so we can localize activity in specific brain regions. And if you want to play with EEG or MEG data now, so these days it's not a problem. There are lots of data available, publicly available. And when it comes to EEG, of course, we're talking about Temple University EEG repository. Again, I just put 10,000, but really it's those multiple data sets and labeled data. When it comes to MEG, So we played a lot with this data. It's a 600. Well, for EMG, it's a sample size much less because, well, collecting EEG is more expensive. But it includes, but in general, MEG data is better, and in the specific data, the cognitive assessment. The problem with the clinical data that we have lots of neurophysiological recordings, but there is no labels which describe people. So usually in the lab setting, there is a researchers collect psychometrics, or like a clinical assessment, behavioral assessment, cognitive assessment, all kind of tests, which, and then you would like to correlate imaging data and psychometrics. And for clinical data, we have only, it's a very diverse data, but not, in my opinion, not enough labels. No, it depends. Like they might, for example, some all kind of cognitive assessment, maybe executive function, or if we're talking about clinical scores, like in autism, so like ADOS score, whatever. Like it's a huge field on the cognitive, behavioral, and clinical assessment, and whatever can be administered. So that's, but this is usually in the lab setting. In clinical setting, they don't estimate cognitive performance because in general it's not their task. Recently, I saw a paper. They talking about almost 300,000 routine clinical scans. So I'm not sure, like, but I'm not sure. Like, I have to check more in detail what data, like what labels are available. And yeah, and there is a journal, Scientific Data. So if you want to browse, because usually they released data, and you can find very interesting data sets. No, it depends. Really, now it's up to you because it might be different EEG systems, different tasks, spontaneous, well, different montages for EEG. So it's all heterogeneity of EEG data is relatively large, but it's up to you to, if you want to combine data, then you have to think about some strategies to normalize data across studies. And finally, I'd like to quickly mention my Mitacs Global Link program. And it says on the website, it's for I think are you familiar with this program? So it's for internship, and it's a year 3 and 4 for undergrads. And if you and students from Ukraine are eligible to apply. And so usually it's before, like in summer, researchers submit projects. Yes. For this specific, yes. I will quickly talk about graduate opportunities for graduate students. But for this specific, yeah, usually it's you have to check the requirements, but typically it's years 3 and 4 for undergraduates. So and if you submit, so you can select some projects. And this year I submitted 4 of them. And so if you Usually, like I hosted, not the previous year, but several years before. So usually my proposals are quite popular. So usually I get a match of students. And how it works, so you submit an application, and then you have to select specific projects. I'm not sure how many, maybe up to 10, something like that. So, and then there is a matching stage where if I guess so we submit our project proposals and students express their interest. So some project, if you apply for this program and if you're interested in this specific project, of course you're welcome to indicate them. And I cannot promise, well, anything, but I can pay special attention to applicants from Ukraine. And there are some chances that there would be a match. Again, it's not up to me to decide. Somehow students evaluate projects, we evaluate students, and Mitacs is agency. They do this matching there, and then for small number of projects, they are funded. So and students go to Canada for 12 weeks. And not necessarily requirements are minimum. So it's a how it's called, the average. Yeah, like, and essentially, yeah, years 3 or 4. So it's a minimum requirements. Yeah, and for graduate students, it's in a way it's easier because there are in general not many opportunities for undergraduate students. For graduate student, well, it was easier before, I would say, like 2-3 years ago, and I was able to. There are also Mitacs programs, and there are like individual projects when I can talk to a student and we can submit an application to Mitacs, and usually it was successful. But these days, situation got worse, and in general, there is no mechanism for, unfortunately, at least for what right now. It might appear in a month or so, but for now, I cannot see a mechanism to invite a student to do a scholarship at SFU, unfortunately. For PhD, those are individual. So usually, if you want to do PhD, then you contact, well, anybody. And usually, like you can apply, but in my opinion, it would not work. Typically, you would need to shop around universities, contact directly researchers, and ask them if they have funding for a PhD student. Because usually, to be admitted to PhD, the professors should have funding. So without funding, they cannot just say, okay, just please come. They have to provide some, at least minimum funding to support you with a scholarship. Yeah, and yeah, thank you for if you have questions, please. Yes, the projects are available online, so you can search those projects by keyword. And In general, I might have funding for one PhD student, and depending on like my colleagues also might have. So in general, if you want to ask, we might also accept like students to do master degree, but in general, I would prefer PhD students because it takes 4 years. I know Vancouver is located somewhere, but it's a nice city. Quite expensive to live, unfortunately, but in general, it's very nice. Yeah, my background is in physics and math, and for PhD, I did my PhD on functional MRI, and then ultimately I switched to neurodynamics, which is like EEG on MEG, and then worked closely with clinicians. So personally, I'm a technical fellow, a technical guy, but I work closely with clinicians and I deal with clinical data and very diverse clinical data. It really, yes, please. Well, whatever works. So for this data was proprietary format natas, and I have problems, actually, but ultimately I was able to convert it to the EDF. But in general, EDF at the first stage, but then it could be other formats. Like for example, we use a Python tool, so-called MNIPython, and they have their own format because it's also keep not just data but the metadata. And sometimes it's easier to keep data in their format. When we go further to the sources, then we can switch to any like NPRA. So it's a really not there's no requirements. It's just whatever works for you. Again, it depends. Previously, we used a lot, MATLAB was very popular, but at some point, we'll start switching to Python. So you have. Like you mean in data augmentation? Again, personally, I did not test and compare techniques for data augmentation. In our case, we did not need it. But I would guess it really depends. So if we have in time series, it's a question how to generate surrogate data which look like real data but noise, and you want to keep some properties. So again, really, it's hard to talk about statistical analysis and data augmentation technique without knowing the problems, because it's all we have to understand what we're doing. That's a key key questions, like why. Usually it's for a paper or grant application. It's not, I know for students it's easier to say like what they do. But it's much harder to say like why we want to do this. So what are our aims? What are our objectives? And this is it's a question for you as a researcher. So like why at first, and then like what and how, it's a secondary. In my opinion, it's an intersection between signal processing, data science, statistical analysis, and some neurobiology. But I think it's at least, again, it depends really on a project. So if it might be to find the clinical, like a very interesting question is the key. And it might be very simple analysis, but if you have a really good question, then it's often I see like engineers tend to apply this. They say, oh, there is this data. I have this very fancy model and a very complex model. I will apply this advanced model to my data, and they say, oh, this is great. And they look at the clinician who just tests like who compute Pearson correlation. They say like, what's like so simple, but really it depends, like, because ultimately question they might develop very complex models for predicting some labels, but then the question is, well, nobody would need this. So again, the question is like why, like why we do what we do, and collaborating with clinicians. It's a very, like, I'm happy to have access to clinical expertise because they can guide me in really understanding what they need, and then I can adapt my instrument as a neuroscientist with a computational background to help them. Usually it's a technical background. So again, it's signal processing, statistical analysis, lots of statistical analysis, and advanced statistics, multivariate statistics, all kind of. And when it comes to statistical analysis, of course, it's a huge field. And yeah, like ultimately, yes. So we try to create some figures to see if those patterns we observe make sense from clinical or cognitive perspective. But because it's, in general, in my opinion, neuroimaging and neurophysiological data like EEG or functional MRI, I saw students with different backgrounds, like a psychologist who would like to learn statistics. But I think in general, people with technical backgrounds are feeling much better, much more comfortable in this field. But again, it's really depends, like, because you like really like, sometimes people with technical background are considered as a like IT support sort of, and ultimately it's a in general, well, for this type of data, I would say yes, it would be definitely a benefit, but it's not. I would say it's not about AI, so it's rather it's a very diverse field, and in my opinion, it requires understanding. It's an interdisciplinary research, and it has challenges and opportunities. It's both. So it's yes. Yeah, there is a lots of papers are coming out to estimate brain age. So it's ultimately, but it's not predicting biological age per se. It's rather deviation from the chronological age. So like if we want to see difference between chronological and predicted age. So some people may be neurologically younger, potentially it should be associated with less clinical symptoms, or vice versa. If the neurologically older people would have more severe clinical symptoms. In my opinion, there is not, for now, I would say we don't, I don't see enough evidence that it might have a really practical application for now. But people are looking into this. Like in blood test, like usually there is a blood test, usually you have a age, like physiological age based on the blood test. So potentially it could be. No, like EEG and MEG are perfectly safe. They are non-invasive tools, and they don't induce currents into the head. or maybe EEG at the very beginning when they test impedances, essentially connection between EEG electrodes and the skull. But again, those are very tiny, whiny currents, so essentially it's nothing at the very beginning. So it's a absolutely non-invasive procedure. I would say MRI is more, it's non-invasive, but it's more, at least it's with MRI, you would inject energy into the head, right? And there are some different restrictions for the time and for the, let's say, 7 Tesla MRI, apparently there are more requirements, more restrictions compared to typical 3 Tesla MRI. Again, this is very diverse. I mentioned different directions. So we're talking about medical text and signals. And ultimately, we want to extract labels from EEG reports and build up models to predict these labels from the EEG data. So this is very diverse. Again, you can think about multiple applications of this. I'm just sketching the key idea for this project. But I was participated in another project like recently we scanned people who has autistic and schizotypal traits. So it was a project with 2 stages, with 2 phases. At first phase, they assessed cognitively and behaviorally lots of people, and then they focused on the 2 extreme cases. So on 2 tails. First, a small number of people which are very close to the autism, and the other subgroup which is very close to the schizophrenia. And it was ultimately a religion project. And then those people were put into the scanner, MEG and MRI, and were showing some questions related to God, human things, and we look into those data, trying to find differences between those groups, 2 groups, and ultimately differences in how religiosity is correlated with the brain signals. Just one project. Another project based on the UK Biobank data. We look into the, also we have diverse data. We have several modalities. Functional MRI on the one hand, then there was a job history and cognitive assessment, and also we have genetics, and we computed so-called polygenic risk ratio scores to evaluate the presence of the predisposition to the gut microbiota, so some gut bacteria, and we try to correlate those, like roughly speaking, correlate these 2 metrics to see. Any other questions? Yes, please. At some point, I decided to apply for a PhD in Canada, and I was choosing between PhD in biomedical engineering based on a functional MRI and an astrophysics. That's it. That was how it looked like. Well, it was a weird application process for me. And somehow I decided, well, I'm more interested, ultimately, I would be more interested in medical physics. Well, in this neuroscience compared to astrophysics. Yeah, ultimately, so it's a very good question, and I apologizing that I didn't mention this at the very beginning. Yeah, so they ultimately want to build up a decision support system to help neurologists in evaluating EEG cases. So, for example, we can build up individual prediction models based on specific neurologists. So one neurologist, based on their individual experience. So when we have a new EEG case, then we can apply those multiple models, predicting normal, abnormal labels. And those models would be based on the individual neurologist. So ultimately, for a new EEG scan, we would have multiple opinions, presumably from multiple neurologists at the same time, like this. And we want to build up, it would be like collective judgment, and we want to build up a system to evaluate those EEGs. Again, there are lots of administrative and technical barriers, and I would say administrative barriers are more severe, because you have to ultimately connect your expertise, your models with a clinical practice, which is a nightmare. Okay. Well, it's improving, but I guess maybe not in the near future, I would say. And ultimately, like, who would take the responsibility? Like, ultimately, we need, for now, we need a person who would sign, okay, like, I'm responsible. It's my responsibility. So we can build up lots of models, and as engineers, we probably don't care, right? But yeah, but doctors sometimes, you know, they'll kill people, unfortunately. In general, yeah, that's what typical analysis would look like. So you have, let's say, clinical group and control group, and then you collect data from both cohorts, and then you applied some statistical tools to find differences between two groups of people. And again, it depends. It could be clinical groups, or maybe if it's a cognitive experiments. Yeah, it's a very good question. Clinical application of EEG, in my opinion, are relatively narrow. roughly speaking, it's about epilepsy and sleep disorders. Those are key clinical applications. Of course, people use EEG in a lab settings and they look into the cognitive function. It's quite popular, but in clinical research, in healthcare, epilepsy and sleep disorders could be, and maybe coma. So evaluate the mental state in coma, in comatose, and critically ill persons. In my opinion, like again, applications are relatively narrow for EEG compared to MRI, functional MRI, which is much more diverse. And MEG, in my opinion, even less narrow. They're trying to, well, it's more expensive, much more expensive. And for example, like in a lab setting, if you want to collect data, like 1 hour of MRI would cost about 600 Canadian dollars. And the same, like 1 hour of MEG would cost the same. While EEG is, well, basically free. It's just, you would need to buy some gel to stick electrodes to the head. But in general, it's the system itself much less expensive and it's cheaper to use. And for applications for MEG, there are lots of cognitive assessment, well, neurocognition, but it's not, in my opinion, a clinical application. They try to adapt MEG for, actually, this is maybe a good picture. When they have a very long signals, but they can focus on like a few seconds. So for example, they can identify the spike, and then they can localize the spike inside the brain with some techniques like a beamformer or dipole fitting in this case. And if it's a multiple spikes are localized in the same place, so they might be more confident, and so they can talk about the locations, the epigenetic zone, and the onset zone, and maybe they're talking about the focal epilepsy, not generalized. Yeah, if we're talking about sleep, again, usually it's done in a lab. So again, people sleep there in the lab for the entire night with electrodes attached. That's a gold standard EEG for in sleep research. Personally, I don't do this, and usually I don't collect my own data. So typically, I rely on data which were collected somewhere. In this case, it's for hospitals do this for us, like every day, essentially. So, so we want to ultimately to develop AI tools based on the clinical data. Again, thank you for your attention. So still, I think there is it one day, if you want to apply, if you're eligible, please check. Again, it's not just, you don't need to select these projects, but so it's up to you. Like, well, there is a multiple project and you can indicate whatever. Well, that's my advice. Follow your interests, of course. I think it's more important. And these days, there are lots of opportunities, in my opinion, for students for all kind of internship, and then for further PhD studies in Europe or North America.